Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome to another episode of the Prolonged Field Care Podcast. This is Colin, and today we will be discussing snake envenomation with Dr. Ben Abbo and Jordan Benjamin. Dr. Ben Abbo is an emergency physician and paramedic specializing in emergency medicine, toxinology, and austere medical care. He has international experience, is the medical director for Venom 1 and 2, Venom Response Units, and Florida Task Force 1 Urban Search and Rescue. Jordan is a herpetologist, remote paramedic, and a leading snakebite researcher with a decade of experience in managing envenomations in austere sub-Saharan Africa. Both of them created the Asclepius Snakebite Foundation, which has some great printable information and resources on the website that we will attach to this podcast. Their infographics even made their way into the Journal of Special Operations Medicine, and they're very approachable if you find yourself in a situation where you need to know anything about this topic, especially for soft medics. They personally helped me during my deployment and are now part of a team rewriting the Joint Trauma Service clinical practice guidelines for snake envenomations, starting with the African guidelines in particular. All of us have no disclosures to make. First, we're going to go over how to prepare for deployment during Antivenom, identifying the various toxins in our patients, management if you're caught without antivenom, as some of our medics may find themselves, and some of the sequelae. So let's get started with a quick myth buster. To tourniquet or not to tourniquet?
Absolutely no tourniquets. Tourniquets have their place for massive hemorrhaging and exsanguination and absolutely save lives, as we've learned from all the military experiences. However, with snakebite envenomation, they absolutely have no place in care. It basically comes down to you have all these toxins in the venom, because the venom is just a cocktail of all these toxins doing their thing. And if you just concentrate it to wherever you're bit, usually the hands or around the feet, depending if you're walking through a field or reaching into something, even kneeling over to tie your shoes, anything like that, whatever extremity you put it on, if you put a tourniquet on that, all those toxins just continue to go to work there. And it's absolutely horrendous, the outcome, just from the tourniquet use.
Okay, so no tourniquets. What about the other myths, such as extractors, putting ice on it, cutting into the wound, or using some of those first aid extractors?
I'm glad you asked that. This is a frequent question that we're asked and an issue that we run into. And oftentimes with a snake bite, one of the best things you can do is not make it worse with bad pre-hospital care. There's a lot that you can do, but you want to sort of start out by not aggravating that problem. And so things like the Sawyer venom extractor, which is, the big yellow kit sold at REI, for instance. It used to be recommended even by Wilderness Medicine Society. And now there's a great body of evidence in animal models, and also we're seeing in people where it's not only been shown to be ineffective, but it can actually make things worse. It seems to, in some cases, be able to concentrate venom just enough to cause worse local tissue injury, but not enough to prevent any systemic effects. And then other things like cutting and sucking, applying ice, these are all things that have been disproven as basically proven to have not only no benefit, but also potential harm.
It makes sense where the ideas came from, but as we got evidence and experience in using the things, we see what more damage it does. Doing things like ice and things of that would cause vasoconstriction is just like putting a tourniquet on, because it keeps all those toxins right there. And I even treated a cobra bite in Florida where on one of the bite wounds, the guy used the venom extractor, and you can drastically see the difference where he used the venom extractor versus where he didn't, and how much damage permanently that guy went through.
So I understand, tourniquets are bad, especially if you're talking a cytotoxic venom. But what about like a neurotoxic venom? Wouldn't you be preventing the spread systemically?
There's a growing body of literature that shows that the way the neurotoxins tend to be able to spread, which is mostly lymphatically, can kind of still creep through there, even though you have the tourniquet on. And overall, you're trying not to do more damage. So there's a real combination of effects that's going on there.
Okay. I'm a medic, and I found out that I'm deploying to a location with some bad snakes, or I'm currently there now. How should I prepare, or what can I do about this?
Overall, you have to be cognizant of where you are going or where you might be going. Just like with any mission, you want to know, do you have the right ammo? Do you have the right water supply, water purification, things like that. So having knowledge and the thought process is the first thing that I would have. It sounds a little corny, but honestly, if you can kind of think through and get an idea of where you can know what's hazardous in those areas. Are there hippos? Are there venomous snakes? Are there scorpions? To help you plan for what equipment you're going to bring. And also just to think, are there contacts that I'm going to need ahead of time? And quite frankly, snakes and wildlife, fauna, flora, they don't read maps, so they don't know borders, but you can get ideas of different areas of where you're going to be and what you're going to need in terms of specific equipment, anything beyond the obvious life-saving equipment that you might need for interventions that we're going to discuss later.
I would add to that. So absolutely great answer. And I would just add a couple of resources that are good places to start. So the DoD actually has something called the Living Hazards Database. It's open source document, and it's basically a list by country. It's a huge PDF. You can click the first letter of the country's name, and it will bring you to a list of what they've compiled as all of the venomous animal hazards there. I will say it's not a perfect list. There's certainly some things missing in places, but it's a really good place to start. I also recommend the WHO's venomous snake database, where you can go in and put a region or a country, and it will spit out a list of venomous snakes that are in that area. And so what I typically will do is actually combine both of those. And I think they tend to sort of catch what the other one misses. And that gives you a generally good idea. But, as Ben said, we often will treat bites from things that aren't supposed to be somewhere. So we never really give it 100% accuracy down to a country. But I think if you look at the country you're at, and if you're near a border, look at the surrounding countries, get an idea of what's there. And then also reach out to experts like us, who can give you some better sort of on the ground advice about, yes, we've worked in that area and these are the main, species of concern.
You guys were definitely some good help to me downrange, as well as your website on the Asclepius Snakebite Foundation. You have some good printable resources that I kept in my bag for these kinds of things, and it made it really easy to understand and digest.
Excellent.
And I know that when you guys do the clinical practice guidelines, it's really going to help out in that format.
Yeah, when you're in the heat of the moment and dealing with these kind of things, to know what resources you have ahead of time so that it's not just in time education if you don't know what's there. So having those resources, you were able to print it out and have it as a resource, and knowing what you had on there is a really important aspect. There are a couple of people from Venom 1 and others like us that are working on having something where you could almost know from the region you're going to have a more complete list, because having a list is one thing, but you do have to work off of those DoD and WHO lists. Okay, so I have a list. Is a snake going to introduce himself as a saw-scaled viper and then bite? No. He's not going to bite and then say, hey, I'm saw-scaled viper. How do you identify and all those different things? Those are some of the other resources that sooner or later will be out.
Okay. So now that we are no longer left of Bang, we have no more time to repair. We receive a snakebite casualty while in an austere situation. And where do I start with my assessment on this patient?
Yeah, it's a great question. So we're going to talk a lot about syndromes today, and Ben's going to sort of introduce you guys in a minute to the various, main syndromes of snake envenomation. I'll just briefly say that we can take all of the snakes worldwide and loosely group them into producing lethal effects and disabling effects that roughly fall into categories of cytotoxic, hemotoxic, or neurotoxic. And there's a lot more to it than that. But keep those in mind when we talk about assessment here, because it's important. And what I want to convey is that we want you all to assess these patients in the same way every single time. So I'm going to give you a system for a standardized snakebite rapid assessment, and this is how we teach it and how we do it. So I always recommend what I call a bottom-up, top-down approach. And that's going to be starting at the bottom of the bitten limb, moving proximally up the limb. So let's say we were bit on the hand. So we'll start there, circle the site of the bite, write the time, mark the leading edge of pain, and write the time and write a P next to it. I usually use a dotted line for that. Mark the leading edge of edema. Look for things like blistering, bruising, necrosis, swelling. These are all signs of a cytotoxic bite initially. Look for signs of a hemotoxic bite, which you'll see locally can include what we call abnormal persistent atraumatic bleeding, which is a fancy way of just saying if you look at that person's hand and it's still bleeding an hour later and it's 2 tiny holes and it's disproportionate, bleeding to the injury, that's an indication of an abnormal bleed, typically, in this case, due to the snake bite. So you look at that, and then, the snake bites progress in a really linear fashion. There can be some deviations there, but the main syndromes will progress sort of linearly. So looking at that local bleeding, moving up the limb, looking for old cuts and wounds that have started to bleed again. Old scabs will dissolve and begin to bleed. Go up to the armpit or the thigh and feel those lymph nodes. Tender lymph nodes is an early sign. And then I end my bottom-up assessment at the mouth. And you always check the mouth of a snakebite victim, especially in Africa and Asia. Your hemotoxic bites, the first sign of a true sort of systemic envenomation that you'll often see with those is bleeding from the gingiva. And it always starts at the very rearmost molars, and it starts as just a tiny trickle of blood right at the gum, between the tooth and the gum. But over time, it picks up and sort of increases in severity. And eventually you can get these patients who show up sort of Walking Dead style, where, you open up their mouth and a big torrent of blood comes pouring out. So I end my bottom up there, again, starting looking for local pain, swelling, tissue destruction, local bleeding, check the mouth for bleeding. And then we're going to do our top down. And in that, you're looking for essentially neurotoxic envenomation symptoms, which will move down the cranial nerves, starting up at the top of the head. So I'll say things like raise your eyebrows for me, follow my finger and don't move your head. Just move your eyes and you'll see that their eyelids will start to droop. The classic sign of a neurotoxic snake bite is an equal bilateral ptosis. So the patient looks like this, and we'll give you guys some pictures that you can put on the website. But they get this progressive drooping of the eyelids on both sides, and it's always symmetrical, and it's always bilateral. And then at that point, the next thing you'll start to see a lot of drooling, and some bulbar muscle weakness, and they're drooling typically just because they can't clear that. They'll start to have difficulty speaking. I'll say, open your mouth, stick out your tongue. That's as far out as they can go. Shrug your shoulders for me. And you can see essentially what we're doing is we're just charting the progression as things move down. And then look for abdominal breathing, look for intercostal muscle retractions, things like that. And another thing I recommend that's really useful for these patients is the single breath count test, where you basically tell your patient to take as deep a breath as possible and then count as high as they can possibly go off of that breath. And normally it's about 50. So you go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You should expect they could make it to 50 in most cases, approximately. And I'm not really worried if they're at 40 or they're at 60. That's fine. What I'm worried about is if they show up at 40 and now 30 minutes later they're at 30 and now 30 minutes later they're at 20. Now we know we have a big problem that's sort of proceeding. And because snake bites are all about progression, your goal is to build up a set of trendable vitals that you can monitor. So again, that's that sort of bottom up, top down snakebite assessment approach. So think about that as we talk about snake bites here today.
Going through this assessment, it sounds like through this assessment, you'll catch just about whatever cytotoxic or hemotoxic or neurotoxic, whatever venom it is or mixture of venom it is. How important is it to actually find the snake and get a picture of it and send it to someone to say what type of snake it was?
So glad you asked it, and especially in that manner. The beauty of how when Jordan came up with this and we kind of built it out more is it doesn't matter what snake bit you or what type of venom it is. This is going to help you manage all of them, and also is going to help you identify what type of venom is there and do it. And the worst thing that can happen is if someone's going to try and catch the snake so they can get a picture of it or kill the snake and bring it in. And by golly, people bring in the snakes and they think they're dead and they're not. People get hurt and bit because they're trying to catch the snake. And even a dead snake can still envenomate and cause some serious permanent damage, even death. So having this approach and it being the same, just like when we do ABC and March and Opioids and all those acronyms, if you do the same approach every time, it's going to help you identify what's going on so that you tell us these things as experts and we can figure out what's going on and get you the right product.
Which a note to follow up on that would be, as medics, even if we learn something such as not to put tourniquets on or not to go find the snake, it's something to educate our non-medic teammates on so they aren't doing the same situation.
I've actually had a mamba bite MCI of sorts where 3 people were bitten by a black mamba, 3 facial bites, because they cornered a snake and tried to kill it, and it came out, of a hut and bit 3 people on its way out. So these, you can see really severe problems from that. Another thing, just sort of like the reason that this works is that all different snakes have different types of venoms, and different venoms cause different clinical effects. And we can take those and treat them with regional antivenoms that neutralize those. So essentially, we can take all of the snakes that cause neurotoxic symptoms, and if we're in a place where there's an antivenom that covers all of those, then we don't really need to know whether it was A or B in order to get the right antivenom at approximately the right starting dose. So we can basically work backwards from the symptoms to figure out what was the type of snake, or at least the group of snakes that bit them. So you go from a medic standpoint, think about it as a progression from read the signs and symptoms, identify the syndrome, figure out what the severity of the syndrome is and how bad that is, and that's going to determine your initial treatment.
So now that we know some of our assessments and what we're looking for, how do I tell the difference between a hemotoxic or a neurotoxic envenomation?
So all the classic teachings and the textbooks and a lot of our exams from the paramedic level all the way up to the physician and PA level, they always talk about, it's you either bleed to death or you're paralyzed. It's a heme toxin or neurotoxin. And it's absolutely not that simple. There's hundreds of thousands of toxins in those cocktails that make up venom, and there are combinations. And they don't just grow up to be neurotoxic or hemotoxic. There's also cytotoxins. There's things that are cardiotoxic and directly attack the heart. But all of these things can work synergistically also. And basically the big syndromes that account for a lot of the morbidity and the mortality would be cytotoxic, because it's doing direct damage right therein. There's heme toxins. And are they making you bleed because it's actually attacking the platelets, or is it attacking the red blood cells, or is it attacking your clotting ability, or is it actually making you clot? And then therefore you use everything up and then you're basically in DIC. There are all these different mechanisms because venom is made for eating. It's made for their prey. It's not made for defense specifically. So there are some snakes that have changed it a little bit to do something like with the spitting cobra, but the venom itself is designed so that it can devour its prey and catch its prey. So those are the initial breakdowns of things, and that's what leads to the different syndromes with renal failure and muscle breakdown is, again, the cytotoxic, the hemotoxic, and the neurotoxic. And those actually I say in that order specifically because there's a lot more morbidity with the earlier on, but the ones that are going to kill you more quickly would be the neurotoxins because you're paralyzed. And of course, the heme toxins being that in between.
And just to add to that, so we're essentially presenting this to you guys in sort of a triage context. So you can see mixed syndromes. For instance, in Australasia, you get a lot of patients who have neurotoxicity with bleeding. In Africa, you get a lot of patients who have cytotoxic and hemotoxic effects. But what we want you to think about is that generally the cytotoxic bites will kill you slower than the hemotoxic bites, which will kill you slower than the neurotoxic bites. So for somewhere like Africa, where we have sort of a broader spectrum treatment option, we can base our dose off of the essentially, there's more that goes into it on the back end, but a higher dose for the thing that's going to kill you quicker. And so if you have a patient who shows bleeding and swelling and neurotoxicity, I don't really want you to worry about the other pieces right there. I want you to worry about the fact that this is now a neurotoxic snakebite. It has other elements, but what's going to kill them fastest? The fact that they're going into respiratory paralysis, in the next hour or two. So,
and you figured out if there's neuro involved, is it just hemo and cyto, or is it cyto and neuro, or just neuro? You've figured that out because you've done that standardized approach that Jordan was already speaking about. So that's how you essentially figure that out. And then with the syndrome specifically, the ones that cause the damage, cyto can cause localized damage because you can see immediate necrosis you might see blood blisters, bleeding, oozing right there. I've seen digits essentially once the tourniquet was on and localizing it there. The fingertips kind of come off, and you see that local damage, and it's spreading from the bite site and goes more proximal. Those are local effects. And not all things are visible. We say, oh, well, there's barely any swelling from a soldier that was just bit on base back home in the U.S. Oh, it's probably just a copperhead and kind of just do its thing, maybe give a little Benadryl, some of these other incorrect things in old treatments. But really, it can be causing a lot of damage underneath. And then you get the myotoxins, because you can have muscle breakdown and subcutaneous breakdown, and that leads to the other syndromes like kidney issues and renal failure. Mm-hmm. With the heme toxins, like I was already mentioning before, where you can attack the different clotting cascade and homeostasis from all that at any different level. I had a girl that was on vacation in Belize that was bit by Brothos asper, also known as the fer-de-lance, which is a really nasty pit viper to get bit by. And she initially was bleeding out all over, pale. Well, she got the Antivenom and initially intubated, sent to the U.S. They extubate her. She actually had a stroke, and it wasn't a hemorrhagic stroke because she was bleeding out. It was an ischemic stroke. And I always remember that because it shows how coagulopathic you really are, not just that you suddenly bleed out. And then with the neurotoxins, it's not like you get bit on the hand and it's my finger's numb, then my finger's paralyzed. Oh man, my hand fell asleep. It doesn't go up that way. It spreads lymphatically and spreads up the actual venom, but the effects and the signs and the symptoms that you're going to see start central. They start bulbar and brainstem. And that's why you see the ptosis, as Jordan was mentioning, or they will complain about double vision. And how do you know that they have double vision? Well, when you're having them follow your finger with just their eyes, one of their eyes is moving and the other is not. And that's because the eye muscles are actually paralyzed. Mm-hmm. And that's what causes double vision.
Just one real quick question. So all these effects, how long are you talking about before they kind of declare themselves?
I can take that one. So the honest answer is it depends. It's one of the frustrating things in snakebite. So it's a field that really is still very understudied. And so a lot of what we know is based on just experience treating lots of cases and seeing things progress. You know, we treated actually a friend of ours last month in Africa for a puff adder bite, and I had an IV going and a blood test drawn 7 minutes after the bite, and he was already in a full-blown coagulopathy. I've also seen a case of a cobra bite in East Africa where the patient went into massive cardiac arrest 18-ish hours after the bite. Prior to that, they had nothing but local pain at the site. And it turns out they were bitten by a dog when they were a child and had scar tissue on their leg. The snake had bit into the scar tissue, which had encapsulated the venom. And essentially it took 18 hours for this to work its way out, busted it open and surged into the circulation. So the answer is it depends. It varies. You know, generally, pain is a really early sign that you'll see in most cases. Coral snake bites, sometimes it takes longer. And Ben should mention something on that in a minute because he's kind of our expert on that. But I will say, you know, with viper bites in particular, pain is almost immediate in most cases, and it's usually sort of a pulsatile throbbing pain. Bleeding, I've seen systemic bleeding as early as an hour. Coagulopathy as early as 7 minutes now. And then neurotoxicity. So black mambas are one of the only snakes in the world that could truly kill you in sort of a sub 1 hour time frame. It's not often that short, but it is often 2 to 4 hours or 2 to 6 hours. A lot of neurotoxic bites can reach a full respiratory paralysis within 6 hours. And, you know, these patients, their heart's still beating. They're still aware of everything that's going on. It's essentially like giving a paralytic to someone. They just can't breathe. So they're, you know, fully aware and alert. So if you can manage that airway, you could conceivably keep them alive long enough to get to antivenom. But yeah, it sort of varies depending on the patient and the snake, and the amount of venom injected and the type of venom. And
snakes don't come with meters, so you really don't know how much was injected. Did they recently eat? Anything like that. So it really depends. And to add on to all the possibilities of the good old air quote it depends. I had in particular a child that was bit by an eastern coral, Microris fulvius, in Florida. And he initially immediately had some symptoms where he was vomiting, he syncopized, and he had this retching and vomiting for an hour and 20 minutes while they went in their personal vehicle to get to the nearest emergency department, which was a freestanding emergency department. And with coral snakes, there's some pain locally, maybe some paresthesias. There's what I call the positive tap test. So it might not hurt. Maybe it aches a little bit. And then someone says, oh, well, yeah, you got bit by a snake. Whoop-de-doo. And you tap on it and it really hurts. It's tender because you're tapping on it. That's how I know with the coral that there's venom there. And he had no other signs, no other symptoms until all of a sudden about 9 to 10 hours later. And we're watching carefully, then all of a sudden, boom, full force, ptosis. Someone had given him food and he's using his hands to close his mouth after he took a spoonful. He can't play video games anymore. It's children's hospital. So of course they've got video games, and he can't play anymore because he's having double vision whenever he could look down at the controller. And he actually had double vision and couldn't run at recess for 7 months. But look at how big of a delay that was.
Right.
And there's reasons why, as experts, we have certain times where we want to make sure, is it truly a dry bite or not?
Right.
But it really depends in terms of the progression. You don't know, with this snake, you're going to always see, within an hour or two, and it's linear. It's who knows.
Okay.
I would like to add one thing to that too. I like what Ben said about snakes don't come with meters, and that ties into sort of an important reason why we do this standard snakebite assessment. So, the initial dosage is going to be based on the severity and the syndrome. It's not on the size of your patient, and that's a really common misconception. And so you, me, and a baby, if we're all bit by the same snake and given the same quantity of venom, and presenting with the same severity of syndrome, we're all going to require the same dose of antivenom. So then the question is, well, if I need, let's say, X quantity of antivenom to neutralize X quantity of venom, how do I figure out how much that is if snakes don't come with meters? And the answer is, snake bites are dynamic and progressive, and an active snake bite will continue to progress and get worse until you give the right dose. So by identifying these parameters that we need to trend, giving the initial antivenom and then, monitoring the response to that, that's how we determine, did we hit the right dose for right now? Or do we need to give more? And you keep monitoring that, over the next 24, 48 hours, you're doing these serial assessments just in case you get sort of releases of venom, which we'll probably talk about later in more detail.
Venom is not like other medications where you have SVT, you grab an antidysrhythmic, you're going to see a change in the ECG, and then you can reassess and move on. Or, you gave the one dose, the loading dose of 12 milligrams of adenosine, and then whatever else, or you're using VFib and you have maintenance infusions, anything like that. It's not that simple. It's much more, you have a toxin, it's a protein, and the only way to stop it is not to just keep taking care of the side effects, is you need to neutralize that predator there. You need to neutralize that protein. You need to neutralize that venom. And the only true cure for venom.
Tampons, actually.
Yeah,
tampons always have to have nearby. But when you say the tourniquet thing, remember, if I can save lives, I could take lives. But the only true cure for venom is antivenom.
Yeah.
And it needs to be an appropriate antivenom.
Right.
Yeah, just to add to that too. So absolutely, antivenom, you're going to hear us say this again and again today. Antivenom is what you need for these bites. We see a lot of bizarre effects too. There's a lot of knowns with snake bites, but there's a lot of unknowns. I've had patients show up where they had unilateral hemiplegic edema. So like everything from the top of the head down to the bottom of the foot on the right side of the midline was completely edematous, like Michelin-Man style, and everything to the left was totally normal, and they were bit on the right side. There's no possible, explanation that I or anyone else have been able to come up with for that physiologically based on this venom. But what do we do for it? Give antivenom, and they get better. And antivenom is really the key to these patients. And the other thing is there's no absolute contraindication to antivenom administration for a patient who has a confirmed snake envenomation and has symptoms that warrant it. So even if you had a history of reactions, you said I've had, 5 bites and I had anaphylactic shock every time, I'm going to say, okay, great. Thanks for telling me. I'm still going to give you antivenom the sixth time if you need it. So, and there's things we can do to mitigate that risk or reduce that risk, I should say.
How frequently are you doing these assessments? So initially, I'm guessing you may or may not see much of any symptoms, outward symptoms like edema, bleeding. You may or may not. And I think what makes it difficult is the people that are in the gray zone, where they think they got bit by something, they're not sure, but they come to you and now you do your initial assessment, and part of you wants to say they're panicking. The other part of you says you probably should wait a little bit and see what happens. Mm-hmm. How frequently are you doing these assessments until you finally get the
Warm and
whatever,
fuzzy.
yeah, the warm and fuzzy, like, yep, this is what it is, and now I'm going to go ahead and send it?
Great question. So there's a sort of a two-part answer. So one is your assessment and treatment intervals. The ones that we use we call them H0, H2, H4. So when you're charting snake bites, it's useful to document the time as things progress. So I always write H or M, hour, minute. Early on, I'm doing, every 5 minutes, every 10 minutes, every 15 minutes as it's progressing quickly. But ultimately, your conditions or your points for re-administering or initially administering antivenom are going to be, if you go by what we use for foundation, H0, H2, H4, H6, H12, H24. And after that, it's up to the provider, based on the findings. Your goal is really, you want control of that thing by, hour 2, ideally. But in reality, by hour 6, you've had the opportunity to give 4 boluses of antivenom. So you really should have things under control. And you should, at the very least, there may be resurgences of venom after that, but your life threats should be dealt with at that point. And then as far as like, when's your warm fuzzy on, I'm pulling the trigger on this being a snake bite. So we'll talk about later on, sort of with the syndromes, there are certain conditions that are absolute conditions for giving antivenom. So like when I'm assessing that patient, if I see ptosis and I have a snake bite and their sugar's good, it's not a diabetic issue that's masking, itself as a snake bite. That's a neurotoxic snake bite. I'm going to give antivenom. If I see bleeding, abnormal bleeding from the gums, boom, condition for antivenom. If I see significant pain, swelling, and blistering or necrosis or tissue destruction occurring, I'm going to give antivenom. So there are these like immediate pull the trigger conditions, and that's what our, bottom up, top down assessment is designed to identify.
There's a lot that goes into trying to decide when you're forward, whether you're military or you're just out doing austere medicine or just out doing austere whatever. To say, oh, we're going to evacuate now, that's a big decision and is not a very quick thing. You can't just call 911 and be like, hey, man, I got to get to the hospital. It's just going to take a little longer, but it'll be by plane or helicopter. It's not that simple. So to make that decision, and then that puts everybody else at risk. And are you using resources appropriately? There's a lot of decisions. There's a lot of things that go into what needs to be said and thought of. But essentially, you're initially doing as many assessments as you can and continuous, looking for any symptoms. Because if it's a dry bite, the last thing I would want to do is call in for a helicopter medevac and use all those resources, give up your cover wherever you're at and whatever you're supposed to be doing, and not be able to complete the mission. But if there's signs of envenomation, that's when you got to start acting quickly. So I would immediately already be kind of thinking about your different game plans, just as you do for any operations you're doing. But your assessment initially is ongoing, and the goal is to find any of those signs of envenomation. And as Jordan said, once you have any signs of it, or for the initial big things that are going to kill you after every couple minutes doing the assessments, then it can spread out a little bit longer. And then, after several hours, then we can kind of declare there's absolutely no signs of envenomation, then it is in fact a dry bite.
Another thing, just like a good sort of peace of mind pearl to remember as a medic, is that if this is a true snake envenomation, it's ultimately going to show its face. Like a true snake envenomation will always reveal itself to you because it's always going to get worse. So they don't just go from being like asymptomatic to being dead. They, will go from maybe being asymptomatic or having just local findings to suddenly they're getting drowsy and they're getting ptosis and their breath count test is going down and their respiratory rate is decreasing. And you're looking at this as a progressing, syndrome. So, learning to remember sort of those cardinal signs of our major life-threatening syndromes. And then, you don't have to be an expert on everything, but know that all of the dangerous life-threatening things will converge, at these three sort of major syndromes. And you will see signs and symptoms show up, and you will see them continue to get worse until you've hit the right dose. So you'll never be just sort of sitting there like, is this actually happening or not? Sooner or later, you're going to be like, oh, this is definitely happening. Mm-hmm. We have a problem.
The one question I have with the neurotoxic envenomations is we have the failure of the diaphragm and those accessory muscles eventually. So we have an airway and a ventilation issue. Self-medics have some things in their hands, such as EMA, the capnography or capnometry. When do we make the decision to take this patient's airway, if at all? And what are some kind of clinical left and rights to help us guide this decision? Because that can sometimes be the hardest part for the provider is you can kind of teach most people the crike, but to actually make the decision to pull the trigger is one of the harder parts on that procedure.
True. The first and foremost answer is it depends. As annoying as that is, but because you have to take into account all these different things. However, there is definitely some clinical signs where early on, it's like, hey man, I really got to pull the trigger. Hey, I can't wait too long. Some of the scariest things for people to do is to do a needle decompression their first time. And they're saying the site over and over and repeating it out loud and lining it up. And then they take their hand off and they do it's like, dude, just dart the chest. Right. It's the same kind of thing. And it's a lot to be able to do it. The skill itself isn't very technically difficult. You're doing a lot more difficult things, but to actually do it is a lot. Some of the signs, and there are different ways to use. I really love waveform capnography. Love it because it can tell you so much. Is it just panic attack? Are they having bronchoconstriction? Is there a pneumo? Is my tube still in place? Are they getting shocky, lactic acidosis? All these different things they can really tell you. And they don't only have to go on to an endotracheal tube. I attach it to a BVM. I attach it to a simple mask or a non-rebreather. In fact, in my little to-go, and my waveform capnographer is tiny. I really love that thing. And it was the first purchase I made when I graduated residency. First paycheck, boom. I didn't get a car. I got my little capnographer because I use it so much. And in with the kit, other than the little adapters, an extra set of batteries is specifically just a mask just to put on, because I can also have you just blow into the little tube, but that can tell me, and seeing it with the strength, seeing if they're able to give me the breaths and count the respirations adequately and kind of see where the strength is going is an important thing. The other thing is pulse oximetry, right? For the most part of the military, you're younger, healthy guys. And when you're young and you're healthy, you have several minutes. If suddenly I hit you with a dart because you wanted a tourniquet, a snakebite improperly. So I say, you know what, bro? I'm going to give you succinylcholine. Boom. I put you down. You're starting out 99, 100%. And as a healthy person, you're going to be several minutes before your pulse oximetry starts to drop. So if they have no other reason for it to be low and all of a sudden they're creeping down and starting to get to the low 90s, you better be ready right now because you're already behind the 8 ball. If they're in the 80s because they haven't been oxygenating well, that's a problem. And so you have to be able to take care of their altered mental status and take care of their ventilation abilities as well as their aeration, oxygenation issues. And whatever that is, you might have the ability to crank somebody. You might be able to put in a supraglottic airway. You might just have oral pharyngeal airways and nasopharyngeal airways and have a pocket mask and do mouth mask. Fine. You just have to have the different abilities and see what you have and be comfortable with doing whatever you need to do.
The austere provider in this situation, I should have by the head of bed of my patient an airway kit with whichever I'm comfortable in, whether it's a laryngoscope and tube, proper equipment, an iGella, the supraglottic, or my crike kit, and then any meds I need, and then some lidocaine and epi if I need it for the crike. Our whole mismade should be right there anytime we have a critical patient like this to ready to pull the trigger.
Absolutely. And I have it there before I remove a tourniquet from a snakebite patient who showed up with one on who shouldn't have had it there in the first place. I know we'll talk about that later. But anytime you're dealing with a snakebite patient, like I want my ABC kit ready to go. And I think of snake bites as sort of ABCA. It's like airway, breathing, circulation, and antivenom. Those are your priorities. And I just wanted to jump back to that sort of austere consideration for airway management thing for a moment. I'm a medic, so I'm a simple man. I really have found that just auscultating, even to just see, are they moving air? And that's the biggest thing you'll see with these neurotoxic bites, is they stop moving air well. They go from big, deep, normal breathing to those guppy breaths. And you look at, there's retractions and whatnot. But if you listen, you just don't hear anything because they don't have that muscle strength to move air. And I love the capno. I love the pulse ox, especially the capno. But don't underestimate the importance of just auscultating and, using your basic tools and monitoring, because that's the fundamental thing that's killing them, is they're not able to move air anymore. So yeah.
Your tips on that. So we went over some of the stuff that can happen if you get bit by some of these snakes, but what happens when I get a guy in that apparently the snake spit in his face, and do I need to take the little freeze-dried plasma that I have, dilute that up, and use that for irrigation? What do I do when I have this situation?
There's actually a lot of people that think that you have to give antivenom for, spitting cobra to the eye. The solution to pollution is dilution. If you have IV fluid, saline, water, wash, anything, you just need to irrigate the heck out of it as quickly as possible. What it basically does is it's going to break down you're not going to suddenly get holes in your eye and become neurotoxic paralyzed. It's like instant cataracts. Mm-hmm. Now, it's not within a couple minutes, but it can be pretty quick. And so just whatever you can do, drinking water, saline flushes, whatever you can do to irrigate the heck out of it as much as possible, terrific. If you have IV fluids, then you can hook up a nasal cannula onto the eyes, and you can prop their eyes open, and just irrigate the heck out of it. Awesome. But the solution to pollution is dilution. And if you have things like the Morgan lenses or anything to help with the irrigation, great. Some people are really afraid to do any tetracaine or anything like that to numb it up. And don't be afraid to. The lenses and everything, you need to keep the eyes open to be able to irrigate. So go ahead, use tetracaine if you have it. But the solution to pollution is what again, Jordan?
Dilution.
Exactly.
I can add something to this. As a herpetologist, so I started out catching venomous snakes and collecting venom in Africa before I got to the medical side. So I'm the idiot in the room who has personally been spit in the eye by a spitting cobra. Other than the fact this is a glass eye, I'm totally fine. No, so I am fine. I can see fine. It hurts a lot. It's instant burning sensation. It's a defensive mechanism that's designed to immediately scare off a predator. So what you need to do is, very quickly irrigate it. I actually had a cobra in my hand. So I had one eye open and I had to bag this thing up and then I could irrigate it. So it was about 5 minutes until I could really flush it. And it was not a fun few days, but it was not a permanent concern. It was a matter of really just, again, treat it like a chemical exposure and irrigate that. I see a lot of these in Africa because most of your spitting cobras are Africa and Asia. Or hobbyists that Ben gets in the States, mm-hmm. People with pets. And essentially any bland fluid will work. I've had people who peed, had someone pee in their eye afterward. And I've had, my favorite one was a woman who was looking for eggs from a bush chicken in Benin. And there was a spitting cobra in the nest that had just eaten the bush chicken and was about to eat the eggs. And so she comes in, and it's important to remember that with the spitting cobras, the venom is essentially like a shotgun spray. So if you're up close, you're getting a full jet of venom. If you're further back, it's more of a diffuse spray. So she leans in over this nest, scares the spitting cobra, takes a point blank shot to both eyes. And then goes through this sort of existential crisis of do I want to waste the eggs right now? And decided she did. And she was totally fine when she got to me. And it kind of makes sense. The albumin in that egg, maybe, particularly grippy for removing those proteins. I don't know. It's a theory.
Really wasting the eggs.
Yeah.
She used them. That was an excellent use of medical care.
Yeah. It wasn't her initial plan, I'm sure, but it worked great. So yeah, water, milk, eggs, urine, rinse it out after. I had a guy who came and was like, I can't see very well in the dark anymore after. And, someone peed in my eyes. And I was like, well, did you wash them out after? He was like, no, that's a great idea. Well, I can't see well in the dark either, but.
So What about the difference between a dry bite versus envenomation?
It all comes down to definition, right? It can't be. I've had somebody say, "Oh, well, this is a physician, right? Oh, there's just a little bit. It's basically a dry bite. There's only a little bit of venom. The thing's swollen, but no, it's pretty much a dry bite, so you don't need antivenom." That's like being nearly pregnant. You can't. If there's any signs of envenomation, it is no longer a dry bite. It is a wet bite. That's the definition. Definition of a dry bite is no signs of any of the effects of venom. And you really need a certain amount of time to be able to declare that.
So, yeah, I can add to this here. So I will say in our standard protocols, we generally say if you have someone with a snake bite from an unknown snake, you're not able to confirm that the snake was non-venomous, then we like to observe them for 24 hours at least afterward. Obviously, I've got a lot of patients in Africa who are like, nope, I feel fine right now. I'm going to go. Not recommended. Again, think about our 18-hour guy. It took 18 hours, then went into massive cardiac arrest. Not really an ideal situation. But jumping back to dry bites for a second, I think it's important. There's a few important things about it. One, it's a great way to help keep your patient calm is to remind them that not all snake bites are snake envenomations, right? First of all, not all snakes in the world are venomous. There's about 3,000 species of snake and about 600, that are venomous, potentially dangerous, and a much smaller number that have killed before. And in Africa, it's around 400 species of snake and around 40 that could potentially kill you. So there's a decent chance you were bitten by a harmless snake. And then let's say you were bitten by a dangerous snake. So obviously we're too big to eat, and venom is metabolically expensive for them to produce. So they don't want to waste it on something they can't eat. So some percentage of the time, and it varies depending on the snake, but on average, we say it's about 25%. It's around 1/4 of pit viper bites. In carpet vipers, which you get in Africa and Asia, it's around 10%. So they have a much higher envenomation incidence. In things like sea snakes and some of our neurotoxic cobras, it can be as low as 50% or as high as 50%, depending how you look at it. So there is certainly, it's safe to say that some decent percentage of bites from venomous snakes will be harmless. Sometimes the history can help point you in a direction of how concerned should you be. Like, for instance, a snake that's physically injured or scared is more likely to inject venom. All snakes can control their venom. And so if you step on a snake, you generally get a worse bite because the snake felt actively threatened. But ultimately, again, the great thing is it doesn't really matter. Ultimately, your patient will show you exactly what's going on by their symptoms.
That monitoring process. So if I have a patient, it's bit because they're walking around in their sandals at night while they're going to use the restroom, am I just staying up with them all night, taking their vitals every 15 minutes? What does that monitoring process look like for you or a remote provider?
It depends on when they come in. It depends on when they come in. Generally, I'm at the bedside for the first, 2 or 3 hours pretty religiously, keeping an eye on things, especially if there's something that could be masking it, like a tourniquet. After a while, when I'm pretty confident that things are not progressing at all, then I'll switch to sort of my standard interval of H0, H2, H4, H6, H12, H24. But if things are dynamic, it's going to tether me to the bedside until I've, sorted that out. There's also, other considerations, like there's a lot of things that can mimic a bite. So we published a paper in JSOM together about a case I had in Benin where a patient showed up with a tourniquet on and he was sort of locally symptomatic, like pseudo-symptomatic. He was bit by a small dark snake, which describes, any number of snakes in Africa. Is not very helpful. And he had some local tremors and local paresthesias, which could be a sign of a neurotoxic bite. But also he's got a tourniquet on for the last 3 hours, and that could obviously cause that as well. And he's sweaty and he's, tachycardic and looks restless and anxious, which could be signs of a snake bite early on.
Or just living in Africa.
Absolutely. He's scared because he's got bit by a snake. And now there's this guy like hovering over him, checking him religiously. So again, the good thing here is that they'll always continue to get worse. You won't be at this point where you're like, man, I wonder if this is actually happening. It's like, oh, I see an initial sign. That sign will get worse. And then you'll see another sign and so on. So
Guys, remember telemedicine early and often as possible. As they said, these things take a while to affect our patients, so we can call and request a snakebite specialist if possible. Anytime you're calling telemedicine, you can always talk to multiple people and try to get them specific to your patient. If I had a burn patient, I'll probably want to talk to a burn specialist more than some of the other specialists to be a little bit more accurate. And now that we've gone over some of the what it looks like on the patients, if we could rehash the assessment now that we kind of know the differences in what we're looking for.
Sure. So, again, we'll start with the bottom-up, top-down approach, sort of our gross snakebite assessment. So first we've done our ABCs, made sure there's no immediate life threats. Always have a Sharpie in your snakebite kit. Now you bust out your Sharpie. I recommend using the same system every time. So for me, I'll circle the site of the bite with a Sharpie. I'll mark the time next to it at the time that the bite occurred. I'll find the leading edge of swelling, which you can't always see. Sometimes you really just have to palpate starting up and move down till where you feel that sort of step off of the woody edge of edema. And I'll mark that with a solid line, and write, E for edema or S for swelling or whatever. And then I'll write H and then whatever time it is, H0, H1, H2. And then I'll find the leading edge of tenderness, and I'll do a dotted line. And this is something that Ben taught me, which I found is very useful, is that the worst pain in a snakebite comes from the venom that's in the body. So pain is actually a super sensitive vital sign for determining have you hit the right dose or not. And so, I'll mark the leading edge of the pain. For instance, maybe early on, you'll see that their swelling is only up to here, but the pain's already up to here. And now you give Antivenom, and then 2 hours later, the pain's up to here and the swelling's up to here. Okay, well, we know we need to give more. So I'm marking that. I'm writing the time. And I'm looking for local signs of a cytotoxic or hemotoxic bite. So I'm looking for pain, swelling, tissue destruction, bruising, blistering, necrosis, things like that. Those are my cytotoxic signs. I'm looking for
fangs still in the skin.
Yeah. So I don't trust, this is a good reminder here. So you shouldn't go by fang marks. And even especially in Africa, like if you get a patient with fangs in there, I've actually had folks who went to the witch doctor and the witch doctor took fangs like out of a box and stuck them in and was like, hey, it was a venomous snake. Again, it doesn't really matter what they show up with. Like they could show up with a black mamba hanging onto their foot. And if they're asymptomatic, then it's going to be a dry bite and they're not going to get antivenom. And that's why it really doesn't matter what the snake was. It matters what the symptoms show. But so going back to that again, look for your local signs of cytotoxicity. For hemotoxic, look for persistent abnormal atraumatic bleeding. And usually what this looks like, if you get a local national who shows up in West Africa, they were bit 18 hours or 3 days ago. And it's not like they're just gushing from the site, but there's a trickle of blood coming out of, this little bite hole. And with regards to the bite holes, you might see one fang mark, you might see two, you might see none. Doesn't really matter. Again, you will see the symptoms and the syndromes progress the same way, or at least those sort of gross general signs or main signs. So move up here, check the lymph nodes, move up to the mouth, open your mouth, check there, with a flashlight. Sometimes you can take a white 4x4 and dab it in there and see if you get blood or have them spit in it. Look for bleeding in the gingiva. Again, it starts at the rearmost molars, starts as a trickle, and then really picks up pace. And then start now you've done your bottom up. You've moved, looking for local signs on the bitten limb, looking for systemic bleeding in the mouth. Now do your top down neuro assessment, moving down those cranial nerves from the forehead, raise your eyebrows for me, follow my finger, make the big H, looking to see whether the pupils are tracking. Open your mouth, so you got your tongue. Do the single breath count test, listen to their voice. Do they have any changes in their voice? Shrug your shoulders. And you're charting all of that and you're charting out your respiratory rate and all of these things. And what you're doing there again is you're just creating a picture of how is this thing responding and, determining is it getting better or worse. And that'll tell you when you've hit the right dose.
Reviewing this takes it right back to your last question too, in terms of telemedicine and who to talk to. There are a lot of people, snake bites used to be a surgical disease, right? Oh, fasciotomy, amputation, even bloodletting was one of the old treatments. And the fact of the matter is you can cause more damage that way. And having the assessment fully, if you're not able to talk to the right person, this is helping you to find any signs so that you can tell them the right thing. And then they say, oh, you know what? There are signs, because there's still people that are like, oh, well, there's no swelling, so there must not be any venom. But I had somebody that was completely hemodynamically unstable, just full autonomic dysfunction from the neurotoxins, and his coagulopathy the coags were through the roof. And it wasn't until the next day that he had any swelling whatsoever. And then within 5 hours of the swelling started, he had so much muscle breakdown, his CK was through the roof, and he was in full rhabdo.
All right, now that we know...
Sorry, can I throw one more thing in there? So as far as coags go, there's something really useful that you can do to check for hemotoxicity in a patient who's not otherwise showing symptoms out in the middle of the bush. It's called the whole blood clotting test. Essentially, we have some stuff on our website, which I think we sent to you guys, and if not, I will. It's really, really simple. When you place your IV, before you flush it, when you just have your line in there, draw 2 or 4 cc's of venous blood. It doesn't really matter exactly how much, and put it into a clean glass container. And it has to be pre-cleaned, and it has to be glass. So
none of the residue that comes in any of those vials or tops.
Absolutely. Like any residue in there can mess up the accuracy of the test, and it won't work in a plastic syringe. You need glass to activate Hageman's factor. But basically, all you do is you take your blood, put it in this clean glass tube, or you could use like an old medicine. Like, let's say you gave some fentanyl to someone a few days ago, and ideally save your glass medicine containers, your vials, rip the top off, boil them, wash them with soap and water, rinse them, and then boil them and dry them and stick them in a little box or bag that says like snakebite tubes. And then put your blood in there, sit it on the table, set a timer for 20 minutes. At the end of the 20 minutes, you pick it up and tip it. And if it's normal, it's a solid plug. It looks like a Jell-O shot, basically. I mean, you can tip it fully upside down and hold it for 30 seconds, and it's not going anywhere. If it's abnormal, you either tip it and it's just liquid and there's no clotting whatsoever, or you tip it and it's initially clotted and then it breaks down after, 10, 15 seconds, or maybe there's a chunk of blood clotting in there, but it's not fully clotted. And so that's really useful for identifying a hemotoxic bite in the sort of asymptomatic phase, where they're not yet suffering from like a massive GI bleed or bleeding into their brain or anything like that. So it's a great way to stay ahead of the curve. And then as you're treating them too, you would expect that you would see that improve, at H2. If initially you had no clotting, you'd like to see some clotting activity at H2 if you gave antivenom initially. And, typically by hour 6, that should be normalized. And conversely, let's say 24 hours after the bite, your patient is complaining of symptoms again. You retest that, and now it was normal and now it's abnormal. That's a great indication that you have active venom that's re-entered the circulation.
We've been kind of dancing around it. So we're talking about antivenom and giving antivenom. How exactly are you dosing it and administering it?
Really depends on, it depends. Yeah. But it really depends on the product that you're using.
Okay.
And that, and are they progressing? Are you getting a hold of it? Because again, snakes don't have meters. So as we're reassessing, so it really depends on the loading doses. We have experience and a lot of literature out there from us and from other people in terms of which antivenoms work in different areas, because you might have somebody that's in Africa and South America and they get bit by a snake and they're like, oh, boom, give Crofab. Crofab's a great product, but it's only a great product if you're bit by a North American pit viper in the U.S., right? In North America. So it's not going to work on a Bothrops asper in South America, the fertile lands down there. So having the appropriate stuff, and all of these antivenoms have different potencies and the different proteins that they're trying to neutralize. So it really depends on the actual product. Mm-hmm. And there's certain things that we look for other than is it working for this species or not? And that's based off experience and experimentation, because there was a cobra bite and they said, well, theoretically, this South African polyvalent is going to work on it because it should work on any cobra. Well, it was an Asian cobra, and in the lab, it works, but clinically, it didn't touch him. And once you gave him the appropriate product, he started waking up. In fact, I said, no, now we got to sedate him and paralyze him because I need more antivenom to go in. He wanted to extubate himself and it wasn't safe yet. So the dosing of whatever product it is really depends on what's going on. And there are other qualities that we're looking for in the appropriate antivenoms when we come up with recommendations.
I think it's, important to think about, all of those factors. And then also, there's practical considerations at play too. I know for me, as an austere medic working off grid in Africa, I don't have refrigeration. And so there's a lot of great products. I've used most of the African antivenoms and had, good experiences with a lot of them. But, if you can't bring something out into the field, then you can't use it. And that's, fundamentally a problem. I don't think we should make any specific recommendations, but in my own experience with our foundation, we've been using an unrefrigerated product that's freeze-dried polyvalent, and we're seeing very good results with that. So I think you really have to look at the region, talk to an expert about what's out there, and then determine the appropriate treatment based on that in conjunction with expert consult.
Okay.
A lot of the antivenoms that are out there, not 100% of the ones that are available commercially are safe, are tested, but there are certain ones that have been, and then there's the other qualities in terms of how do you dose it, and can you refrigerate, can you not, transport to places. I'd rather have something that's, as Jordan said, stable, so I can have it in my backpack and ready to go. So when we were in Guinea, we had stuff in our bag, and I knew that if we got bit in the middle of nowhere, we can start providing care right away. And it's really important because it's not just about surviving. We're trying to prevent permanent pain, permanent disability, and permanent disfigurement.
Okay. What about side effects? I'm giving this. I've never given, antivenom before. What would I need to know to know about what to expect from my patient, or things that may go a little awry, if any?
Most of the antivenoms are made via injecting horses, and then they develop the antibodies. So similar to blood transfusions, where you can have a transfusion reaction, you can get serum sickness just because it's of where it's derived from. And there's potential also to have full anaphylaxis or anaphylactoid reactions. And how do you clinically tell the difference if it's anaphylactoid versus anaphylaxis? I don't know. Maybe if you slow it down a little bit and it seems to get a little bit better, cool, maybe. But really the only difference is spelling and theories. So, but most of the time, if anything, you get a little bit of serum sickness, you get a rash, some urticaria, some hives, which that doesn't automatically mean, oh man, stop the antivenom and they're going into anaphylactic shock. You need to do an assessment, just like any medication you're going to give. So you can have a little bit of the rashes, a little bit of the itchiness, but you do also always look for signs of anaphylaxis or anaphylactoid. So is their voice changing? Is there belly cramping? Are they vomiting or retching? Do they have the urticaria? Do they have the runny nose, the rhinorrhea, things like that? Or do they have any signs of angioedema? And that's where the GI symptoms come in also. That's angioedema just inside. With any of those, then I would stop. Doesn't mean we're not going to give them any more antivenom, but you need to treat those things, and those are the signs of what you're going to look for.
And I think these are some of the considerations too to take into account for field treatment. One of the biggest things that we want you guys to take away from this is not to be afraid of antivenom, right? Like, again, the worst case scenario that happens is that you induce anaphylaxis. Anaphylaxis treatment is bread and butter emergency medicine. And they've looked at fatalities from anaphylaxis in snake bites in the United States and found that they were in unmonitored beds generally. So these are patients in like rural hospitals who somebody gave them a Black Widow antivenom, an older generation, which was particularly immunogenic. And then they just left the room, didn't have them on a monitor, came back in, and they were, great idea. And they were in cardiac arrest. So if you're watching your patient like a hawk, if they have a reaction, you're ready to treat it. What's much worse is not treating them and then having them suffer a permanent, disability. The newer generation of antivenoms, is designed to be used in austere settings. It's, the stuff we're using with our foundation in a SERP, the reaction rate is around 1% anaphylaxis. And that's generally, if you talk to various antivenom experts, they argue that 1% is around what you'd expect just in a population due to hypersensitivity. Maybe some guy eats horses and that, hypersensitizes him to it, for instance. The overall reaction rate, with anything there is around 8%. And that's things like nausea and vomiting or, urticaria or a dry cough. So most of the time, the effects that these have are very mild. It's the same with Crofab, super low incidence of anaphylaxis. Now, why were people scared of antivenoms? Because the older generation of products had reaction rates that were upwards of 35 or 40 or 50% or higher anaphylaxis. And again, I've used those products in Africa before we had these sort of field stable products. And it's fine. It's not a great fun experience, but it's a lot better to treat them and be prepared to treat a reaction than to not treat them and watch this person spiraling from an envenomation. And so, there's different reaction rates in different areas. Certainly, if you're working in Asia, there are some products that are safer for parts of it, but there are other parts that don't have really good safe products right now. And the reaction rates can be as high as 40% or higher.
Note on the anaphylaxis. You said it's a bread and butter emergency medicine, but we do good by doing well at the basics. Mm-hmm. And sometimes people really mess it up with the basics. So medics need to understand that epinephrine is your true treatment. Some get so wrapped around the axle about getting that Benadryl on board as if that's helping them right in the immediate moment. It needs to be epi, and it's not always one dose of epi. You have that biphasic or refractive anaphylaxis. So you do that one dose, be prepared. Don't just say he might need, just be prepared to send that second one IM if he needs it. And then if you look in your tactical medical emergency protocols or other guidelines, look for your push dose pressors as well as your dirty epi drip. Every medic should know those two, just like the back of their hand. They shouldn't be looking in a manual for 12 to 18 minutes while your patient's blood pressure is going from 80 to 70 to 60 to 50. You don't have that time, so every medic needs to know those two skills for anaphylaxis and not just snake bites in general.
There is nothing else. 4 things that I hope that listeners get from this is, number 1, don't use a tourniquet on a snake bite. 2, know that there are experts that care and that want to help get information out there. 3 is know how to treat anaphylaxis, because Benadryl, a lot of people are get Benadryl, that's the cure. Benadryl is not the cure. It just helps with some of the symptoms. And by golly, if you're out, mission forward, and you have someone who's anaphylactic, the last thing I want to give them is something that's going to sedate them, because then they can't walk out, and I don't want to carry them in their pack out, right? So the cure, though, anyway, is epinephrine. Benadryl helps with things, but it's the epinephrine. And then the 4th thing is to not be afraid of giving antivenom when you need to. There are absolutely great products that are out there because if you have an envenomation, the venom is going to do its damage and quite potentially kill you or your patient. If you don't do something, it's going to continue doing its thing.
This has helped people be a little bit more comfortable with understanding antivenom, be willing to push it, but a lot of remote and military medics working downrange may not carry this. So if we have this confirmed hemo or neuro patient downrange, what can our management be? I know that antivenom is the gold standard, but if we just don't have it, what is our prognosis, and what are some things we can do to maybe buy them some time or manage this patient, if anything?
Don't talk neuro, I'll talk hemo.
That sounds great. All your life-supporting measures, everything you're already trained on to deal with exsanguination, airway management, ventilation, needs to absolutely be remembered so that you can take proper care of them. That's what mostly it comes down to, and get them to the product, or get the product to them as soon as possible. Some specific things that people are trying or have tried, you don't want to do more damage, so don't put the tourniquet on, things like that. But you might get to a point where you need to do transfusions or other treatment. And we both have various experience with that.
Just, in West Africa, we get a lot of bites from carpet vipers, which kill more people than any other snake worldwide, and they do it with a bleeding syndrome. Couple things with that. One is, you may need to give blood to these patients to stabilize them. In some cases, the late presenting patient who was bit in their village and came 20 hours or 40 hours later could be presenting in hemorrhagic shock. So in those cases, Ideally you're giving blood after antivenom because one, antivenom will fix the problem, and, two, it will prevent things from getting worse. But if they need carrying capacity because they're in hemorrhagic shock, then they need blood. And that's fine. And you need to give blood to keep them alive. You can give more once they've been treated with antivenom. Also, sort of adjunct treatments like TXA, unfortunately, don't work with snake bites. The venom works with a different mechanism, so it just wouldn't do anything. But fortunately, in particular with African and Asian snakes, antivenom is excellent at resolving the bleeding syndrome. So you can almost think of it like TXA for a bleeding snake bite. The bleeding will usually stop within, minutes to the first maybe hour or two max once you've hit the right dose.
Blood transfusions, would they need it? When if they do?
I've never needed to give somebody a blood transfusion after even very severe life-threatening envenomations, but really you shouldn't be giving any blood transfusions or any products until at least assess a couple hours, an hour or 2 hours after you've gotten them antivenom.
I have given them in Africa when we were out of antivenom and didn't have any for a few days. And I had a patient who I think her crit was like 11. She was in very poor shape.
Indicator.
Yeah. And so, typically, again, for me, if I'm in the middle of Africa and I'm limited on stuff, I'm going to check the mucosa, the color, look and see if that's blanched. I'm going to look at their, blood pressure, their heart rate. I'm going to ask about a history of bleeding. Sometimes they had a history of bleeding before, but it stopped by the time they showed up, and now it's just internal.
Just knock duct tape on something. Just, if you can, give them the antivenom. So let's move medicine forward so we can get it out there in the field.
So if we start to have the 6 Ps of compartment syndrome develop in our patient and we're eating through Artiva and all of our ketamine, do we pull the trigger on this fasciotomy, call telemedicine for it? What about?
Absolutely not. When you're even if you confirm, because you stuck a needle in the compartment and confirmed compartment pressure properly, and that there's compartment syndrome, you still should not do a fasciotomy. This is not a burn. This is not a crush injury. This is a different mechanism to what's doing it. So you're going to actually cause even more permanent damage. Remember that you have cytotoxins, you have hemotoxins, a variety of things, and it's just going to be a worse outcome. And we really want to get our coworkers back working again, not have permanent outcomes, permanent deficits.
What are some of the nursing care and prolonged field care considerations and maybe some adjuncts or ancillary treatments we haven't gone over yet?
For one, pain management is absolutely vital. We have great research that's come from the military and other places where, adequate pain management up front for whatever the injury is has avoided or had less PTSD and different things like that. So pain management is number one. And I usually go with opioids and ketamine. Our experience in Guinea, especially, we were using ketamine. It was just working terrific, and then got them through, get them antivenom, and then they were able to switch to just Tylenol. And then all of a sudden I had a guy standing on his bitten foot. Those are some of the funniest pictures I have. And then the other thing too is elevation. A lot of people are taught to not elevate, in fact, keep the bitten extremity low. It's not very easy to elevate someone's leg while they're walking. That just really looks funny. But absolute elevation can really make a difference. If there's swelling, the edema and all can shift. The edema might not disappear. It might just shift from the hand going down to the armpit or anything like that. But if you can elevate it, I'm talking, I should walk into the room and their foot looks like it has a question. That's appropriately elevating. And that is going to help with things drastically.
So elevating is more important for that venous return than it would be for any chance to make the venom move faster up or anything like that?
The venom is going to still be the same speed. It spreads lymphatically. It gets in the system. But also, we're going to get them the product that they need, the antidote that they need, and that's the antivenom. Okay. Doesn't matter where in the body it is. It's going to work.
The next note, so I guess we didn't train our team good enough, or you work with a junior medic who didn't listen to this podcast, and he slapped a tourniquet on that bad boy snakebite, and it's been on there a hot minute by the time it gets to you. So what are some considerations when the tourniquet's already on, especially with the prolonged times?
I'll take this one. I get this a lot in Africa. Tourniquets are often applied by locals when they come in, and maybe it's a real tourniquet, maybe it's just a piece of cloth wrapped around, or as they do in Guinea, like 5 different pieces of cloth tightly tied. The bottom line is what you don't want to do is simply remove that in one fell swoop. Rip it off, and then if there is venom in there, a big bolus of venom can surge into the bloodstream and cause a rapid collapse in some cases, or a very rapid progression of symptoms. And so an asymptomatic patient with a tourniquet, or even a locally symptomatic patient with a tourniquet, if they have any signs of systemic envenomation or local envenomation that warrant antivenom, like blistering, necrosis, bleeding from the gums, ptosis, these signs of paralysis, anything like that, I'm going to start antivenom before I remove the tourniquet. If not, I'm going to do a slow sequential tourniquet release where...
How slow?
Essentially, I will take the tourniquet, loosen it a tiny bit just for maybe a half second or a second, tighten it down again immediately, and wait and monitor their vital signs, wait 5 minutes or 10 minutes, see if anything developed. And then if nothing developed, I'll repeat and do again a little bit more. Typically, I would say I do this, sequentially over about 30 minutes. If at any point you see signs of an envenomation develop, you start your treatment before you remove it. And then once your treatment's been on board for, another 30 minutes or so, you can continue to sort of sequentially release this. So it's important to do it slowly and methodically and not just, took the tourniquet off, see what happens.
So much slower than if we had a tourniquet on a traumatic patient and we did that, 1 to 2 minute conversion. We're doing this over like 20, 30 minutes.
Yeah.
You want to slowly get in there? Okay.
Your goal is to get just enough venom out that it starts causing a problem without causing a problem so quickly that you're not prepared to deal with it.
Okay. Note of giving that patient some anti-venom before taking the tourniquet off. We kind of glazed over. Do I give this in a bag, or can I just shoot it in IM, or how do we administer antivenom?
There's a lot of talk in terms of putting a lot of money into having universal products and having universal antivenoms, and even people that try to vaccinate themselves with homeopathy and stuff like that. The antivenoms specifically are treated different ways, but it's all intravenously. You can't give it intramuscularly. It needs to be IV. And depending on what you're using for an antivenom, Jordan was using in Guinea our product we would just do it right into the vein, right into the IV, into a lock.
We reconstitute it and give it over 3 minutes by a slow direct IV push. And again, that's something we can get away with this new generation of products, which have a better safety profile. So we're not as worried about things. They used to put it in a bag and hang it and say, oh, if you had a reaction, stop the drip, treat the reaction, and then restart it after an hour. But that's a lot of wasted time. So it's advantageous to be able to give something, reconstitute it, takes a few seconds to mix, give it by direct push at the bedside. You're tethered to the bedside for 2 or 3 minutes. You're watching that patient. You have the antivenom on board.
Antivenoms, you need to reconstitute it, and you put it into an IV bag, usually normal saline, maybe a 50 cc bag or 100 cc bag, and then do that IV through that way. What you don't want to do is accidentally people misread instructions and they reconstitute it, and then they have 5 different bags with 1 vial in each one.
That'd be a lot of fluid for the patient.
Yeah.
I see on some of your resources that you have grades of envenomation. Is this really important for every medic to have memorized? It's super important during the process.
Great. Yeah, it's a great question. So it's useful to know, but the most important thing that you should be aware of is progression, right? All envenomations are characterized by progression. So, a grade 2 is up, for swelling is up to the knee, but not past it. And a grade 3 is up to, the shoulder, but not past it. Does that really matter to you? No. What matters is, was the swelling below the knee? And now 2 hours later, it's above the knee and halfway up towards the shoulder. Well, that tells you that you haven't controlled the swelling yet, which means that there's still enough active venom in there that you're going to need to give more antivenom. So I'd be much more, I think it's much more important for you guys to focus on learning the signs and monitoring progression rather than worrying about putting a number on something.
Okay. Any further notes or last comments for the podcast, guys?
Yeah, I'll throw something out. So I think the best outcomes with snake bites come from a combination of getting the right antivenom at the right dose into the patient early, having expert-derived protocols that take into account some of the things that you need and simplify it down. And then making sure that your team is trained in snakebite management, because this is not something that's taught in medical school or medic school or PA school or whatever. It's a small community of people that do it, and we're trying to change the way that this is done, but it's certainly an uphill battle. And so the best outcomes that we can get come from, early treatment. And the sooner we can move people towards that, the better I think our patients will be.
Absolutely, time is tissue, right? And around the world, every few seconds, somebody dies. Every few minutes, somebody dies from snakebite envenomation. And for those that don't die, they have permanent pain, permanent disability, permanent disfigurement. The earlier that you can intervene, the better the outcome is going to be.
Yeah.
So you can't be afraid to give antivenom. If it looks like it's warranted, then it's warranted. So we have a very simplified way to assess. We have the mechanism out there, and there's some very safe antivenoms already out there. So we don't need to hope and spend billions of dollars on trying to come up with a universal. We have things that are already out there. They'll work in different environments. And what we really need to do is try to push so that we can get the care right out there. Not even at maybe the boo, maybe even right there at the point of injury, at the point of envenomation.
That's really, as we move forward with the CPGs, that's kind of what we would like to get to, is to have you guys being able to give antivenom right away. I think also a sobering statistic to remember when you think about this is that there's good evidence that shows a minimum 1% increase in mortality for every hour wasted between the bite and the first dose of antivenom. And in reality, it's probably much higher because the patients that die in the first few hours are never accounted for. So take that and analyze it, and all we can say is it's really important to treat early, and you're going to get better outcomes for your patients.
Thank you for your time, Dr. Airway and Jordan Benjamin. I appreciate your help personally, downrange, and all the stuff you've done for the locals and other assets in the countries that you go to, and giving back to the medical community as a whole. Thank you.
You guys, we appreciate what you're doing as well.
Thank you for having us. It means a lot.
Yeah, thank you.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.